Hi, very good morning, everyone. Welcome to our yet another session. We are live on 1st of November, 2025, and we are entering winters. Uh, we have a very important topic and a very important speaker. I will have Dr. Monica Vasudev, especially to introduce the speaker. Dr. Monica.
Thank you, Saurabh, and thank you, Samao, and thank you to all the attendees today. It's my pleasure to introduce our speaker of today, Dr. Anuj Maheshwari. So we are delighted to introduce Dr. Maheshwari, a distinguished physician and academic leader in the field of medicine, hypertension, and diabetes. He is a professor of medicine at HIMSS, Sitapur, and adjunct professor at KMC Manipal. He has been recently awarded the Mastership of the American College of Physicians, becoming only the fourth Indian to receive this honor. He currently serves as the president of the Asian Pacific Society of Hypertension and vice president of the Asian Heart Society, and is also the president-elect of RSSDI, which is the Research Society for the Study of Diabetes in India, for the 25-26 cycle. As well as he is the Secretary General of the Indian Society of Hypertension. With over 110 papers presented and 102 research publications in leading journals, Dr. Maheshwari has delivered 18 orations at national and international platforms. He has received several prestigious recognitions, including the World Hypertension League's Notable Achievement Award, the Health Icon Award, and the Well-Being Champion Award by the American College of Physicians. His remarkable contributions as a clinician, researcher, and educator continue to inspire the medical community in India and abroad. Please join me in welcoming Dr. Anuj Maheshwari. Welcome to the platform.
Thank you, Dr. Monica Vasudev, for the kind introduction. So I shall be talking today about the critical connection between diabetes and hypertension. And it's really very much needed for everyone to understand, not only for the doctors, but also for the common man, so that whenever they are having the diabetes, they should take care of their hypertension. And whenever they are having high blood pressure, they should think that they may not be getting the diabetes together or not. So can I share my slides right now? So hope everybody can see my slides. Can anybody will confirm?
Yeah, please. Yeah, perfect.
Yeah. So next few minutes we shall be having a discussion about the critical link between hypertension and diabetes. We all understand well that diabetes is increasing very fast globally. Currently, the 285 million individuals are having the diabetes, and it is projected in 2030, 439 million people shall be having the diabetes. So 6% population is currently having the diabetes, and we expect that 8 to 10% population shall be having the diabetes in next 5 to 6 years. And when we talk about the diabetes, about 40 to 80% of the diabetes patients have the hypertension. Hypertension means high blood pressure. And as far as the diabetes is concerned, two times are they are likely to have the hypertension. Means a common man having the propensity to develop hypertension, a diabetes patient is having two times chances of getting the hypertension as compared to the non-diabetic person. On the other hand, hypertension population is also rising very fast, like a jet speed. Currently, we have 26% population of the globe suffering with hypertension, and it is projected 29% population shall be having in 2030 or next 5-6 years of the globe with hypertension. But very important to understand and very interesting, it could be that India is having 3 times prevalence of the hypertension as compared to the prevalence of diabetes. Around 11% people are having diabetes in India, while 35% people are having hypertension in India. So hypertension is more common in individuals with diabetes. This could easily be understood by this data. At the same time, we should also need to understand the complications which may occur because of the uncontrolled hyperglycemia in diabetes patient, because of the uncontrolled hypertension in diabetes, high blood pressure in hypertension, once these two are together, they increase the risk of all those complications much more than they are having alone. Like brain strokes are having the two times the risk as compared to the singleton any diabetes or hypertension is having, or any one of them is there with any of the patients. As far as the peripheral vascular disease is concerned, diabetes increases risk by 2 to 4 times. At the same time, if blood pressure increases in its severity, the risk of the peripheral vascular disease increases in that ratio. 3 times people are having likely having 3 times people are having likely to have coronary heart disease. 2 times they may have the left ventricular hypertension. 3 times they may have the congestive heart failure if they are having the diabetes and hypertension together. Microvascular disease like kidney failure, like retinopathy, they can be more than 70% reaching to the end stage renal disease if they are having hypertension or diabetes, any one of them. But once they are together, then you can understand and you can simply imagine what would be the ratio of development of microvascular disease. Similarly, microvascular disease also includes the retinopathy. It also increases the risk of the retinopathy. Let's talk about the diabetes and hypertension in India. As I already said, currently the India is having the hypertension about 35% of its population, diabetes in 11% population. Almost similar complications, almost similar risk factors. But most important thing is that these complications rising very fast in both the diseases, and once they are together, they may not make it 1 plus 1 2, they make it 1 plus 1 3. So age is standardized, state level prevalence of the diabetes and hypertension, rural urban divide is different. But very soon we can see that rural urban divide is converging very fast, and rural hypertension, which was much lesser than the urban hypertension earlier, now is exactly going to touch the level of the urban hypertension. Let's have a few words about the putative mechanisms whereby diabetes and hypertension both cause the vascular complication. Vascular complications could be macrovascular and microvascular, both kind of the complication. You will be surprised to know that diabetes and hypertension, although these two diseases are there, but both of them are reaching to the similar level of the complication through the similar kind of the path. Diabetes ending up with the hyperglycemia to the advanced glycated end products, and it reaches to the microvascular complications very fast. Another mechanism is the RAS activation, immune activation, where the immunity is suppressed, and people are developing the macrovascular and microvascular disease because of the hyperimmune activation. Oxidative stress. Obviously, whenever we are having these two diseases together, the inflammation rises multiple times, and this becomes the reason of the oxidative stress. Reactive oxygen species are accumulating in the end organs, and they are becoming the reason of malfunctioning of those end organs through the macrovascular and microvascular complication. As I already said, inflammation and oxidative stress, as well as the immune activation and hyperimmune uh, phenomena, they all are interrelated and increasing each other. MicroRNA is also having a role in development of the macrovascular micro. But most important to understand is that these diabetes and hypertension, which are taking up us to the similar kind of the complications, similar pathway, they are arising of common soil that is called as insulin resistance. The insulin resistance makes that common soil, which gives rise to the diabetes and hypertension both together. Diabetes approximately doubles the cardiovascular disease risk in patients with hypertension. If we look for the vascular process whereby diabetes, hypertension predisposed to cardiovascular disease, you can see that almost similar risk factors like genetic predisposition, like insulin resistance, like dyslipidemia, or being overweight or obesity, they all are behind both the diseases, diabetes and hypertension. The same risk factor, same changes in the same pathological changes in the organs like atherosclerosis, like endothelial dysfunction, vascular inflammation, vascular fibrosis, arterial remodeling. And atherosclerosis and endothelial dysfunction is majorly responsible for the macrovascular disease, while the vascular fibrosis and arterial remodeling is ending up with the microvascular complication, and both together with making a cardiovascular adverse outcome. Very important to understand it here. Once a person becomes a diabetes, 15 years before of the development of the diabetes of the present cutoff what we are having, he starts developing the endothelial dysfunction. This endothelial dysfunction starts occurring in the inner wall of the arteries, through which it starts becoming roughened, and lot of platelets and cholesterol materials are getting deposited in the internal wall of the artery. And this endothelial dysfunction becomes the foundation for the atherosclerosis, which takes up around 10-15 years to convert into the cardiovascular disease or coronary artery disease, or depending upon the arterial blockage, if whatever the artery is being affected with the endothelial dysfunction. But this is because of that diabetes which is going to come after 15 years. Many times it happens person gets the heart attack 2-3 years before development of the diabetes as per the current cutoff. Many times people ask this question every year or every 2-3 years. We are seeing that cutoff for the diabetes diagnosis is going lesser and lesser, and probably this may be having some malintention towards the benefit of the industry, pharma industry. But actually, it is not that. Actually, it is an endeavor to catch the earliest people, those who are going into the cardiovascular adverse outcome because of their endothelial dysfunction, which is occurring because of the forthcoming diabetes, which yet to come up. And all of us wants that earliest and earliest we can catch those patients who are going to have this adverse outcome. So phenotypic characteristics like which is associated with hypertension in patient with type 2 diabetes. Male people are having comparative predominance. Familial hypertension is having predominance for the development of high blood pressure, especially if the diabetes is there. People, those who are having the increasing age, with the increasing age, the chances of the hypertension increases. With the increasing weight, the chances of hypertension increases. With increased the diabetes duration, the chances of getting the high blood pressure increases. EGFR plays an important role since it is lesser, the blood pressure is increased, and once it is higher, the blood pressure is high. So once the blood pressure is normal, once the EGFR is higher. As far as the EGFR is reducing, the blood pressure is increasing. You can see the opposite effect of that. Microalbuminuria. Having more albumin is being passed from the urine, more of the hypertension. Background retinopathy associated with the hypertension. Advanced retinopathy having more strong association with the hypertension. As far as the myocardial infarction or stroke are concerned, they are also having strong association with the hypertension. Let's have few very important things which makes the blood pressure and hypertension very complex in setting of the diabetes. In the patients of the diabetes, more commonly we see the isolated systolic hypertension. About 65% of the diabetic individuals develop isolated systolic hypertension, where only systolic blood pressure is rising, diastolic blood pressure remains at the normal. Challenging situation remains once we start trying to reduce the systolic blood pressure, the diastolic blood pressure also starts coming down. And this becomes a challenge for a physician. Without changing the diastolic blood pressure, how can he do the wonder of reducing the systolic blood pressure? Because isolated systolic blood pressure is as much as harmful as the systolic and diastolic blood pressure together are, especially in a diabetes patient. They have got the more variability in the blood pressure. They are prone to develop the orthostatic hypotension. What is the orthostatic hypotension? Once the person is changing the posture, standing up, his blood pressure is falling. Having hypertension which is more resistant to the treatment in diabetes. Experience less reduction in nocturnal blood pressure and higher baseline heart rate than their non-diabetic counterpart because of the autonomic neuropathy, which is more commonly seen in the diabetic individual. What is happening here? A normal person who is not having any disease is having his blood pressure drop in the night time. That we call it the nocturnal dip in the blood pressure. And whenever we are sleeping in the night time, we see that blood pressure should fall, used to fall around 10 to 20%. But many of the times it is not falling. It happens in the patient with the diabetes. When heart rate is also not being changing, blood pressure also not being falling in the night time, then it is a signal of alert signal for the forthcoming danger, which may come in the form of the stroke, which may come up in the form of the MI. BP control in these patients presents a great challenge because the target BP is quite low and the response to the treatment is very poor. So this is the picture what we can see in the isolated systolic blood pressure. But in the patient, those who are 80 years of the age, this is very commonly seen. What should be really thinking of them, those who are 80 years of the age, which because it is because of the stiffening of their arteries, and as the age is increasing, the stiffening of arteries is increasing. In that case, you can see that diastolic blood pressure remains the same, but systolic blood pressure is high. Dipping status, as I already said, 10 to 20% of the blood pressure dipping between the daytime to the night time on an average happens. Those who are having less than 10% dipping, they are called as the non-dipper. Those who are having rise in blood pressure at the night time, they are the reverse dipper. And those who are having more than 20% dipping, they are called as the extreme dipper. All the three things are pathological and they should be avoided. And we should always look for that dipping should remain 10 to 20% from daytime to the night time. This is the picture of the normal dipping, what you should see in a normal patient normally, normal study. ABPM, ambulatory blood pressure monitoring, is the best way to identify this dipping so that we can make out whether the patient is having white coat hypertension, whether the patient is having mass hypertension, or patient is having non-dipping because of the diabetes or any autonomic dysfunction, or there is the extreme dipping. Now, what are the factors behind this non-dipping? Why do we need ABPM in diabetes? Most of the time, in the morning breakfast, we take the high salt intake. Sometimes in the night time, what the alcohol has been taken, smoking is taken, cold temperature because of the some temperate countries, and especially the countries where the temperature is changing, like India, northern India, where we see that some months remains very cold and some months remains the normal temperature. Then in those situation, morning hypertension is very commonly seen. Asian ethnicity is prone to have the hypertension. So these all patients, those who are having high salt intake, those who are having alcohol habit, smoking habit, those who are living in the cold temperate zones, Asian ethnicity, they should be exposed to the ambulatory blood pressure monitoring. Then people, those who are having high level of the work stress, high level of the home stress, those who are not doing the exercise, doing the smoking, having the daytime hypertension or having the stressful condition, living in the stressful condition, they should be having the exposure of the ambulatory blood pressure intake. Nocturnal hypertension is one of the important outcome of the high salt intake in the evening meal. Chronic kidney disease, those who are having already or having prone to develop the chronic kidney disease, they also develop the nocturnal hypertension. Diabetes patients, sleep apnea, insomnia, Asian ethnicity, they are making a person more prone to develop the nocturnal hypertension. What does it mean? Means once a person is sleeping, his blood pressure is either rising or his blood pressure is not falling. In both the condition, patient is more vulnerable to develop the atherosclerotic cardiovascular disease. So once we do the ambulatory blood pressure monitoring at minimum 21 time in a day times and 7 night time measurements must be done. Nocturnal hypertension or nocturnal non-dipping is conveys the worst prognosis regardless of the 24 hours blood pressure. The absence of the normal dipping and dipping magnitude predicts the mortality in hypertensive patient. What we see, this is the picture where you can see multiple troughs and down where you can see that nocturnal dipping is there, but there are certain hypertension segments which could be because of the exercise or some stresses which are coming up in the daytime and the night time. This is a normal phenomena what we see in usual patient. When we see about the masked hypertension, what is a masked hypertension? Masked hypertension, when the patient is coming to the doctor's clinic, his blood pressure is normal. But once he is at the home, his blood pressure is high. And it's really very, very difficult to detect. This can only be detected by the ambulatory blood pressure monitoring. But unfortunate thing is that prevalence of the masked hypertension is approximately 10% in the general population, but is higher in patients with diabetes. So whenever a person is having diabetes, his blood pressure is found to be normal in the doctor's clinic, we must have once time look about the mass hypertension and check the ambulatory blood pressure monitoring whether his patient is not having high blood pressure, especially the patient, those who are passing the albumin in their urine, especially the patient, those who are having the dyslipidemia, or those who are having their diabetes not getting under control despite multiple tries and multiple medicines has been started. So this is the picture where you can see that systolic, diastolic hypertension, especially in the situation of the non-dipper kind of the patient. This is another very important picture where you see that blood pressure is rising in the night time. And this is the picture what we usually see in patient, those who are having Parkinsonism, those who are having autonomic dysfunction, where instead of falling in the night time, blood pressure goes high in the night time. So this is autonomic failure picture. ABPN in diabetes. Diabetes, you can see that is stage 2 hypertensive dipper. You can see it here that blood pressure is rising in the daytime, all the daytime, but it is falling in the night time, but not up to the mark, 10 to 20%. Less than 10% is falling. Non-dipper, where you can see that it is again having the almost similar level and less than 10% falling is there in patients with diabetes. A diabetic patient develops CVD at 2 to 3 fold the rate observed in non-diabetic. Hypertension is one of the most significant risk factors for the arteriosclerosis. Hypertension as a complication in diabetic patient increases the frequency of developing cardiovascular disease by 2 to 3 fold. Compared to the normotensive, non-diabetic, a rate of onset of the cardiovascular disease is 5 to 7 times higher in patients with diabetes and hypertension. If you look over to the cerebrovascular disease, means strokes. Hypertension, mainly the systolic hypertension, is strongly and directly related to the stroke in all age groups. The presence of diabetes more than doubles the risk of stroke in patient with hypertension. Lowering BP in patient with hypertension and DM reduces the risk of stroke by 54%. Diabetes is a salt-sensitive hypertension. Many patients believe to have salt-sensitive and they have got the high glomerular blood pressure and a flatter pressure diuresis curve. Because of what they develop the hyperinsulinemia, which is outcome of the insulin resistance, also involved in accelerating the reabsorption of the sodium from the renal tubule. So more of the sodium is reabsorbed in the renal tubule. So always keeping a level of the sodium high in their blood, and it becomes the reason of the hypertension or high blood pressure. Excessive salt intake makes it more and more complex. It inhibits nocturnal blood pressure to come down. Standardized association of the 10 mercury systolic blood pressure reduction with mortality and macro and microvascular outcome in type 2 diabetes patient has been done in multiple studies where we could see lowering of the blood pressure reduces the mortality, reduces the cardiovascular disease, coronary heart disease, stroke, heart failure, renal failure, retinopathy, as well as albuminuria. Morning hypertension has significantly higher frequency of developing nephropathy and retinopathy. So morning hypertension gives you an idea that this patient may go into the nephropathy or kidney disease very soon. Frequency of the development of the cerebrovascular disorder also significantly higher in patients those who are developing high blood pressure in their morning time. Prevalence of the microvascular, macrovascular events in hypertensive and normotensives with or without morning hypertension is making this different. The characteristic of the circadian rhythm of the blood pressure is there and it is determining the 24 hours risk of cardiovascular disease and could be catched by the 24 hours ambulatory blood pressure monitoring in patients with diabetes. ACE inhibitors and ARBs. That's why they are supposed to be the most important and most supportive drug because they not only reduces the albuminuria, they are not only reduces the incidence of the renal outcome, especially in the setting of the hypertension and diabetes. These are the medication which should be used to start with the treatment because they are the biggest protector not only towards the blood pressure lowering but also towards the insulin resistance. More intensive BP lowering improves the CV outcome or cardiovascular outcome, irrespective of the baseline systolic blood pressure and atherosclerotic cardiovascular disease. Mortality and cardiovascular outcome with the RAS inhibitor, renin-angiotensin inhibitors, compared with the calcium channel blockers in patients with type 2 diabetes. Here you can see the more things are in the favor of the RAS blockers as compared to the calcium channel blocker. In India, majority of the physicians remains more comfortable in using the calcium channel blocker. Very few physicians start the treatment with the RAS blocker. But RAS blockers definitely is not many times it may not be so much perfect in reducing the blood pressure, but always they are good for giving the additional benefit of reducing albuminuria, kidney protection, which is more important. And of course, the blood pressure lowering is one of the major benefit what we look for the antihypertensive treatment. Mortality and CV outcome with RAS inhibitors when we compare with the beta blockers, then obviously the RAS blockers are having the great edge over the beta blockers. Look for the hypoglycemia. Hypoglycemia is also one of the important reason for the hypertension and arrhythmia. Many a patient, those who go in frequently in the hypoglycemia, they develop arrhythmia, they develop blood pressure high, 10% many of the time reported dead in bed syndrome. They just die in the night time when they are sleeping because of the arrhythmia or hypoglycemia which could occur in night. Arrhythmia during hypoglycemia likely reason for the increase in CVD deaths observed during strict blood glucose control. And relative risk of the cardiovascular disease occurring during serious hypoglycemia is reported to be twofold. So there are certain medications which are available nowadays, like SGLT2 inhibitors, like GLP-1 GLP-1 receptor agonist, like liraglutide, like semaglutide, which are not only reducing the glycemic status but also working on the hypertension front. They reduces the blood pressure too. There are beneficial effects of the SGLT2 inhibitor in addition to the decreasing the blood pressure, decreasing a uric acid, decreasing the glycated hemoglobin, decreasing the glycemia risk. It also has the beneficial effects on the lipid profile, decrease oxidative stress, reduces the sympathetic nervous system activation, decreases the arrhythmia, decreases the inflammation, arterial stiffness, and myocardial fibrosis. At the same time, also helpful in decreasing the weight. Effect of the SGLT2 inhibitors on HbA1c, body weight, and systolic and diastolic blood pressure could be seen quite encouraging in multiple studies. Algorithm steps for the treatment of the hypertension in patient with type 2 diabetes. If the patient is having blood pressure more than 130/80, he should be considered as hypertensive. But till the 140/90, we can think about an expectation of lowering less than 130/80 by simply diet and exercise or lifestyle modification, which includes the yoga and other methods of the lifestyle modification. If the patient having blood pressure more than 140/90 but less than 160/100, monotherapy works most of the time. But if the patient is diabetic, we must start with the RAS blockers, either ACE inhibitors or ARBs. Even in non-diabetic, this combination and one of them, not they should not be used in combination, and one of them is always beneficial. But in case of the blood pressure is more than 160/100, the dual therapy is preferred, and sometimes it is also needed to be triple therapy. Dual therapy, now it is recommendation that even in patient those who are first time being detected as hypertensive and even having their blood pressure more than 140/90, instead of starting of the monotherapy, they should be started with the dual therapy. It can help us getting the two pathophysiological background of the disease together at the same time. The toxicity of the drug is also not very high from one drug. Both the drugs may be having their complementary and supportive action with each other. The points to ponder: for patient with blood pressure more than 120/80, lifestyle intervention consists of the weight loss if overweight or obese. A dietary approaches to the stop hypertension means diet scheduled and making in a way to stop the hypertension means at least 4 to 5 servings of the vegetables and fruits must be ensured in a day, and this includes the reducing sodium and increasing the potassium intake, moderation of the alcohol intake, or better to stop the alcohol, non-smoking, and increasing the physical activity. Patient with confirmed office BP more than 140/90 should adopt lifestyle therapy and have prompt initiation and timely titration of the pharmacological therapy to achieve the BP goals. And BP goals should always be less than 130/80 in a diabetes patient. Patient with confirmed office BP more than 160/100 should adopt lifestyle therapy, have prompt initiation and timely titration of the dual therapy. Two drugs start together or a single pill combination of the drug demonstrated to reduce the cardiovascular event in patient with diabetes. This is having the A criteria of the evidence. And ACE inhibitors or ARB, these are the molecules, the maximum tolerated dose indicated for the BP treatment, the recommended first line treatment for hypertension in patient with diabetes, and especially those who are having urinary albumin creatinine ratio more than 300 milligram per gram of the creatinine, or 30 to 299 is the creatinine. If one class is not tolerated, then you give the another class, but both the classes should not be given together. ARB ACE inhibitors should not be used together. For patient treated with an ACE inhibitors or ARB, diuretic, serum creatinine or EGFR and serum potassium levels should be monitored at least every year. Selection of the anti-glycemic drug also play an important role, not only in hypertension control, but also in cardiovascular risk reduction. So that's all from the today's presentation. We should not forget that people with high blood pressure, diabetes, those are conditions brought about by lifestyle. If you change the lifestyle, those conditions will leave. So important is to understand lifestyle modifications are the most important way of treatment. It should not be forgotten at any stage of the disease, even when the blood pressure is 160, 100 or more than that, and when the kidney disease are there, still the lifestyle modification works. But in those conditions, it will not work alone. It will be working with, if it is associated with the appropriate therapy. So it is important not to leave lifestyle modification anytime. Thank you very much for your kind listening.
Thank you so much, Dr. Maheshwari, for a wonderful topic and insightful information about, uh, I think, a very, very common problems about diabetes and hypertension. We will open the forum for the question answers. Anybody else? Anybody has a questions over here?
Good morning, Sharab,
So,
and good
Doctor,
morning to. Can you
yeah.
hear
So just
me?
yeah, yeah.
Yes, yes, we can hear.
Just before we
Uh,
open the question answers, I would like to welcome Dr. Anil Kakri. He's the president for SEMAO. He has taken over last month. Dr. Anil, are you here? He's busy. He will join in soon. Dr. Akhtar, please go ahead with your question.
Hi, Mahesh. It's one of the great presentation. A lot of information. The problem with our patient, despite of advising lifestyle, dietary, and medication, what is this psychology of this our patient? With the consultation, they say I don't eat anything, I'm strictly on diet. But when you observe their cholesterol is high, BP is high, and the weight is gaining, is it true they are sticking with the diet? And when I have seen patient, my own patient in the function and all, they are the one eating everything, whatever is available, and they say don't eat anything. So, is there any psychological change of those patients? Thank you.
Uh, it's very interesting question, Dr. Akhtar. And in fact, this psychology of the patient has to be changed by us. And we can do this by providing them the current information. Like today, I have given a lot of informations to you, and these informations are to be passed on to the patients also, so that they can understand and they can change their psychology. That if they are doing, many patients are having the similar psychology what you are telling. If they are doing the lifestyle modification, they think that they don't need any medication, and once they start medication, they think that once I am on the medication, then what is the use of reducing sodium in the food, then what is the use of reducing salt in the food, and why should I go for the exercise, and why should I reduce my glucose level. So these kinds of the mindset has to be changed by awareness sittings with the patient. Multiple educational sessions are needed to be taken with the patient, and these kinds of the meetings what we are having today can also work well for those kinds of the patient.
Thank you so much.
Dr. Kakri, were you speaking something? Can you unmute and talk? Are you back? Dr. Anil? So, Dr. Anuj, meanwhile, when he's back, first my question is for general public, not for doctors. I know doctors knows the answer. What is the real blood pressure, normal blood pressure? Because some people say it's 120 by 80. Some people say it's 130 by 85 is also okay. Some people say age plus 100 plus age is normal. There's a lot of things. So I have realized a lot of people, they come back and say, yeah, Dr.
Hello.
Kakri,
Yeah. Yeah. Good morning.
good morning. Dr.
I was
Anil, yeah.
middle of reading. Hello.
Yes,
Am I
please go
audible?
ahead. Yeah, you audible.
Hello.
I think Dr. Anil, your network is pretty slow. Your voice is bluffing, but yeah.
My voice is coming or not
No,
coming?
your is okay. Your is okay.
Yeah, so I can tell you the answer in the meantime. Dr. Anil Vikram
Yeah,
gets
yeah.
connected. Answer
Hello.
of your question. What happens exactly? This kind of the change in the opinion, it keeps on going, even the people those who are related to the medical science also. What happened in 1942 when William Roosevelt has died? Before his death, just a day before his death, his blood pressure was 180 by 120, and their physicians called it normal. And next day, overnight, he died. And later on, there has been a concept that whatever the blood pressure, if it is higher, it is good. And that concept is still working in our most of the peoples. But I suggest if the blood pressure is lower, is the better, because it will not give rise to any heart attack or brain stroke or any kind of the thing. Now come over to the what is the current status of the blood pressure. It is the textbook recommendation as well as it is accepted by all the organizations that blood pressure is normal once it is less than 120 by 80. Means less than 80 systolic and less than 120 is the less than 120 is the diastolic and less than 80 I'm reversing. Less than 120 systolic blood pressure and less than 80 diastolic blood pressure is supposed to be normal. It does not mean that everybody will be having 120/80 blood pressure. 120/80 blood pressure will not be even in 5% to 10% people, but it should be less than that. Now question arises, what we call it rising blood pressure. Once it is between 120 to 130 systolic and more than 80 systolic or touching the 80 systolic, it is called rising blood pressure or elevated blood pressure or raised blood pressure. Means blood pressure is in the normal limit but on the higher side. Once it touches the 130 and once it touches the more than 80, then it becomes the call for reduction. Means if it is crossing the 130, you need to bring it down less than 130. If possible, less than 120. But if it is not possible, at least you should keep maintaining between 120 to 130. And diastolic should always be less than 80. Initially, you should try with the lifestyle modification. If it is less than 140 and less than 90, you can take a chance with the lifestyle modification only. But if it is more than 140 and it is more than 90, then you should add the lifestyle modification, but only as a adjunct to the pharmacological therapy. It should not be taken a chance only left over the lifestyle modification if the blood pressure is more than 140 and 90, because till the time the lifestyle modification bring it down, lot of damage it would create in our end organs like kidney, like brain, very small capillaries of the brain and kidneys, which are having their individual unit in themselves. And once the capillary blood pressure rises, they gets blocked. And in brain, they causes the loss of memories. In kidney, they causes the reduction in the performance of the kidney. And when we come to know it is more than 50% of the nephrons are lost, then mostly we come to know that this has already had happened. So most important to keep the blood pressure less than 130/80 at all the time. If possible, less than 120/80, good. Not possible, not more than 130 should allowed to go.
Sure. Sure. Dr. Angelique, you have a question?
Thank you so much. Thank you so much for this very informative lecture that you gave us. I just want to make one or two comments and maybe ask your opinion on this. So what we sometimes see with not only diabetes, with our patients is they will come into the surgery and tell you that, you know what, this morning my blood pressure was elevated. It's elevated actually every morning when I wake up, and when we take the blood pressure, it's normal. You then sit with a situation in the surgery where you find it normal, the patient insists that it's abnormal in the mornings, and that's actually where your 24-hour BP comes in, which we as a rule do in our surgeries. But I have found that sometimes there's a natural spike just after they woke up. As you've said, they take their first cup of coffee or have a smoke or whatever, and up it goes. And if you react to that BP, you're going to actually do more damage to that patient, especially if it's an elderly patient, and you increase the blood pressure tablets without double checking whether it was just a spike, a normal spike, if I can call it like that. Any comments on that? Thank you.
Yes, very interesting condition. And in fact, you must be knowing it that European Association of the Hypertension and European College of the Cardiology has added in its guidelines a category elevated blood pressure. Elevated blood pressure, they call it, once it is ranging between 120 to 130 and once it is touching to 80 and getting it. So this elevated blood pressure is also a alert signal, especially in patients with uncontrolled hyperglycemia. Many of the time, we think that if my blood pressure is less than 130 and 80, many patient comes to the ICU when you say that their blood pressure was absolutely normal when they have been brought, but their blood glucose level must have been very high at that time. And if at that particular point of the time in the morning hours, if blood pressure is found to be rising as compared to the rest of the day and rest of the time, then it is a signal of alert that something wrong is there and this is to be kept down. And many times it is seen that once you blood pressure is high and you have taken a cup of the coffee in the morning, it further increases the blood pressure. Then these small things of the lifestyle modification must be told to the patient that in morning hours, if you are finding that your blood pressure is more than 130 and more than 80, 85, then you should not start your day with coffee or any such kind of the stimulant. Many people start their day with the smoking. Many people start their day with the, when they go to the toilet, they use the smoking before going to the toilet. Many people start their day with the tea. Many people start their day with the coffee, and they should be taking care of this thing. If they are having their kind of the tendency, they should not use at the beginning of the day. They should avoid it all the time. If they cannot, at least they should not use in the beginning of the day. That is my take.
Thank you. Dr. Ashraf?
Thank you very much, Saurabh. Thank you very much, Professor Anuj, for a wonderful talk. Indeed,
you.
it is a problem of the world, not only of our continent, India, Pakistan, Bangladesh, or the underdeveloping countries. My concern is just a simple question that you said that the rural areas, they are increasing diabetes and hypertension. In your opinion, what are the reasons? I do understand this socio-economic burden and the depression or anxiety,
Yes.
that is one of the factors that give the increase. But in your opinion, what you have research or understanding about this, can you share, please? Thank you. I'm from Lahore, Pakistan.
Yes, I think rural conditions of the living are not very much different in India and Pakistan. So they are almost same. The rural people in India also consume the tobacco and tobacco products. They also consume this hookah. They also consume the country liquor. Similarly, these things are must have been consumed. I can simply presume. I have not seen in the Pakistan also. May not be country liquor, but definitely I can understand the smoking and tobacco products might have been definitely be more popular there. So these are the reasons for the hypertension, and these are the reasons for the continuously rising blood pressure. What happens nowadays, something has been added which causes the rise in blood pressure, like social media, like mobile phone, like continuously awakening for the late night, being on the social media, making comments on the others, and sometimes this is also giving you some. Uh, uh, Sometimes it may also be causing you excitement. Sometimes it is also giving you some enragement. Maybe become you angry of somebody's action, and unnecessarily this is changing or playing with your blood pressure without any reason. Even when you are seeing the cricket match and some team is losing and some team is winning, our blood pressure is unnecessarily revolving ups and down. I have started my practice when I was used to handling so many patients in the emergencies. When I reached to the 50 years of my age, I stopped attending the emergency just for the reason the patient remains in the emergency at time. Your own adrenaline is also going up and down. And that becomes a very difficult situation. You are going up in the night and going to the hospital, and your own blood pressure is being played up with the condition of the patient. So these are the conditions which are usually really can give you the difference of the urban and rural populations and their change in the blood pressure depending upon the circumstances. So in current situation, I can say that rural population is on the higher danger as compared to the urban population. In next few years, you will see that rural population probably crossing the prevalence of hypertension rate may be the urban population, because lot of efforts we are doing towards the urban population. We are explaining them what are the risk of the hypertension. These kinds of the program like IJCP is doing can be reaching to the urban population, but they may not be reaching to the rural population. So they may not be knowing about all these things, and they may not be taking enough care of all these things also. In India, we have started some rural outreach program through our RSSDI Research Society for Diabetes in India also, but they are still at the very initial stage, very nascent stage, and we need to work very hard to make the rural population protected from the hypertension and diabetes kind of the disease, especially from their adverse outcomes.
Thank you very much. Thank you, Anu.
Thank you. Do we have any other questions? Dr. Monica, do you have any feedback or comments from US? I think it's a very important topic.
Hi, thank you for a fantastic talk. And I really love these conversations on metabolic diseases, which has an unfair, disproportionate representation in the parts of the world that we represent, either through heritage or by geography. I think what I really appreciated about your presentation was the graphics. And I think I look at your graphics and I say that when we're doing an assessment, we're taking a snapshot, a photograph. And what are we taking a photograph? We're taking a photograph in the movie of a person's life. And a photograph only tells one piece of the puzzle. So if you're getting a blood pressure assessment and you're doing it in the morning or doing it in the evening, it's reflecting a different physiology of that same person. So if a person has a sense of satisfaction or sense of confidence to say that my blood pressure is okay, it doesn't necessarily mean that it's always okay. And if it's elevated at one point, doesn't necessarily mean it'll be elevated all the time, but utilizing the times and the blood pressure, like you said, to minimize stimulants, minimize things that can aggravate blood pressure, really focusing on lifestyle and putting the ownership back on the patient so that they feel empowered, that they can take care of the factors that can elevate their blood pressure, I think is a very valuable lesson that can be taught over and over again and should be shared in every conversation between a physician and a patient. So I appreciate your talk and thank you very much.
Thank you. We have a quick question and then I think we will wind up the session. Can aggressive control on one condition can improve the outcome of the other problem?
No, not at all. One aggressive, definitely, this will reduce the danger which is occurring because of the same condition. But how can you expect that it will reduce the danger which is occurring because of the diabetes? Obviously, the complications which are coming jointly together definitely be reduced. You can say that this complication could have been occurring because of the diabetes, but I have made my hypertension better control. I could get less chance of get. Definitely, it will happen. But it has its diabetes, hyperglycemia, uncontrolled hyperglycemia has its own share towards the complication occurrence, and uncontrolled hypertension has its another own share. And of course, the share of the hypertension is much bigger than the hyperglycemia share. So, because more 35% population is suffering with the hypertension and only 11%. But the dangers of the hyperglycemia are bigger as compared to the hypertension. So both the things cannot be said that one is at the cost of other. Both are to be controlled together simultaneously.
Do we have any other questions on the floor? Dr. Kapri, if you're here, please give your final comments if your network is there. I believe his network is still not there. So in the interest of time, we are on time. It's an hour session. We would like to say thank you to Dr. Anuj Maheshwari for the wonderful topic. I think this
Thank you.
hypertension and diabetes is technically covers most of the patients in the world, not only in India. So I think if these two things are controlled, especially with the lifestyle modification and the diets and the sleeping habits, and then to the pharmacologically, treatments. If that is there, I think you should consult your doctor. But this is one of the things which you should have under control. High diabetes and high blood pressure is something which is a slow killer, and it can defect and hamper your other body organs. So, Dr. Anuj, just take home message for everyone, and then we can wind up the session.
Just keep your blood pressure less than 130/80 in all the time. Those who are having their blood pressure high and taking the medication for that. Those who are not yet started their medication, they should try to keep their blood pressure less than 120 and less than 80. They should keep their blood glucose level less than 100 after the 8 hours of the fasting in the morning, and less than, it should not be rising more than 140 after the meal, also 2 hours after the meal also. If we can really make it, then nothing will happen to our health, and we shall have a very good life, a quality life for a longer time. Thank you very much.
So, thank you so much, and really a very, very insightful information. I think if anybody else has a question, please write on the Facebook or wherever you are watching it, and we will ask that directly to the expert. With this note, we would like to wind up this session. Thank you, sir, for joining in, and thank you all the dignitaries over here for this session. See you again next session. Thank you.
Thank you, Saurabh. Bye
Yeah.
bye.
Thank you. Thank
Bye.
you.
Thank you, Saurabh.